Thank you, Faria, for asking me to chair
Yes.
this session. This session is very important for each and every diabetologist and thereby also to the diabetic persons. Uh, Dr. Samad is the speaker of this session, and he is well known mostly nowadays for his capacity of organizing healthcare system. But to me and to him also, he is a basically endocrinologist and a product of the Badam Academy. Today, his speech is on a subject which will definitely help us to recapitulate or to refresh our
Darwin?
knowledge. And this knowledge is basically an art and science combination. How to initiate, how to break the barrier, and how to intensify the insulin therapy with the aim
Darwin?
of having a safe, normal life for most of the diabetic patient, uh, uh, be he or she is GDM, be he or she is a type 1 or a type 2 patient. Now, without losing time, may I request Dr. Samad to start his deliberation. Dr. Samad, please.
Thank you, Chairperson, sir, and good morning to all distinguished persons, participants, and my colleagues. My topic of discussion is initiation and intensification of insulin. Before going to my main lecture, I'm showing some facts and figures, and this has been derived from the Atlas of Diabetes from IDF 2009. You see, estimated about 463 million people are diabetic. It is estimated that about 1 in 11 adult is having diabetes. Age group is 20 to 79. Likely, very alarming is about 1 in 2 adult is still undiagnosed. So that is estimated about 232 million people. And 3 in 4 people with diabetes live in low and middle income countries. Again, if you look for the treatment cost, about 10% of global health expenditure is spent on diabetes. That is about 760 billion US dollars. And if you look for the IGT, impaired glucose tolerance, about 1 in 13 adult is suffering from impaired glucose tolerance. That estimates again 374 million people as per IDA. And if the age group is above 65 years, 1 in 5 people are having diabetes. That is almost equal to 136 million people. And what's about type 1 diabetes? In children, adolescents below 20 years, about more than 1 million children are having type 1 diabetes, which is increasing. But another alarming situation is this: about 20 million pregnant ladies are having hyperglycemia. That is about 1 in 6 live births. And among them, 84 of which is due to gestational diabetes. The situation is really alarming. So, what is the scenario in Bangladesh? If you look at the slide, in 2017, the number of people suffering from diabetes was 69 lakh, and 2019 it came up to 84. And if the trend is like this, it will be 1.5 crore in 2045. And 2019, about 1 lakh people died due to diabetes and its complications. This is a very common slide, but I have to show a person before developing diabetes, they left a considerable time having IgT. And after 4 to 7 years, you see, as it is a progressive disorder, insulin resistance increases, beta cell function declines, and insulin level, that means insulin secretion, is also declines. And the present interest is the incretin. The incretin secretion is also declines. As a result, the person becomes full-blown diabetes, both fasting and postprandial glucose shoots. And as time goes on, the person develops micro and macrovascular complications. You see the macrovascular complication, coronary artery disease, peripheral arterial disease, and stroke. And the people are having CV death and higher incidence of amputation and even CVD and death. If microvascular complication happens, the person can lead to blindness, renal failure, you have heard in the previous slides, and amputations also because of wound and infection. This is the most important slide you see. A meta-analysis showed that postprandial glucose has a stronger correlation for HbA1c than fasting plasma glucose. But when the contribution of fasting plasma glucose increases with worsening diabetes, so fasting plasma glucose, postprandial glucose, and hemoglobin A1c, both three, they forms the glycemic triad. So we should do? We should have the target for treatment. And as per ADA standards of care 2020, hemoglobin A1c should be less than 7. Preprandial capillary plasma glucose should be 80 to 130 milligram per deciliter, and peak postprandial capillary plasma glucose should be less than 180. You know, Bangladesh Diabetic Association also set a guideline and the targets for our population. The fasting should be 7, post-meal should be less than 10, and hemoglobin A1c should be less than 7%. So you see, good glycemic control matters, but often we are delaying to initiate the insulin. Wikipedia says if you can reduce the hemoglobin A1c by 1% even, that can reduce microvascular complication by 37%, myocardial infarction by 14%, and diabetes-related mortality by 21%. This is very much significant. And retrospective database analysis also showed that diabetes-related treatment costs can be lowered by 25% if you can keep hemoglobin A1c below 7 continuously for 1 year. And all of us know because of continuous use of OAD and during diagnosis, already persons came with 50 to 70% beta cell damage. So why we should delay to initiate insulin? There are some barriers, that is understandable barriers when considering insulin initiation. You know, fear of hypoglycemia, weight gain is a concern, and fear of injection also. And we have to take the smart strategies to overcome these barriers. Even in US, you see, after initiation of basal insulin for 2 years, hemoglobin A1c is more than 7% in 71% population. And in UK, after 3 years, it showed that 60% have no change of hemoglobin A1c, and only 90% they intensified their insulin regime, and only 14% they have changed their regime. So if the barriers are matter actually, so simple strategies should be taken to overcome these barriers. What we said earlier, along with these, I can add the complex regime the patient will not accept this. The lack of patient adherence is also important, and increased need for healthcare professional. This is the resources. All of us know insulin is can reduce hemoglobin A1c, than any other oral hypoglycemic agents. This is the greater hemoglobin A1C reduction with insulin only and insulin only. So we have to initiate insulin, optimize it, and intensify it. As beta cell mass declines whenever there is diabetes, we have to start with lifestyle modification and oral anti-diabetic agents. After that, as time goes on, we have to add the basal insulin with oral antidiabetic agents, then optimizing it. That means titrate the dose, reach or maintain the glycemic targets. And again, as time goes on, when beta cell mass declines, we intensify or basal, then basal bolus or premix insulin we have to give. Again, if there is no control or control is lost, you have to intensify or you add another mealtime insulins, one or more shots. This is if early insulin therapy can improve beta cell function. This is clear and glycemic control. You can deliver the insulin in CSII, that means continuous subcutaneous insulin infusion or multiple daily injection is needed. There are various insulin regimes, but before initiating any regime, you have to keep in your mind the following key points. You have to balance the work and family of the patient, his hectic lifestyle, complicated insulin regime, and risk of hypoglycemia. He should you should look for the dependent parents or elderly persons in the family and responsibility of the children, high carbohydrate meal, and even erratic meal pattern. Treatment is always individualized. Whenever you are choosing any regime, you have to keep in mind all these factors. And the regimes are basal only, basal plus only, basal bolus, split mix, premix, and modern insulin co-formulation. We know in Professor Ashrafuzzaman's slide, you saw there are various guidelines and recommendations. But we have many guidelines and recommendations for insulin initiation and intensification. If we take the idea of guideline, they have advocated to initiate insulin with basal once daily or premix once daily or BID and intensify basal plus or basal bolus like this. If you look at the ASC guideline, you can start with the basal and during intensification, you add GLP-1 receptor agonist or prandial insulin premix among other options. ADA guideline says you can start with GLP-1 receptor agonist or basal and prandial insulin during intensification. But there is ADA and ESD consensus decision on insulin initiation. It says if there is significant hyperglycemia with symptoms and or there is sudden rise of very high blood glucose concentration that is more than 300 milligram per deciliter or hemoglobin A1C is more than 10%, you have to add insulin or you have to initiate insulin. If there is continuous catabolism, that is continuous weight loss with symptoms of hyperglycemia, you have to add insulin. And of course, where there is OAD failure, you have to initiate with insulin. You know, Bangladesh Diabetic Association, they set forth a guideline in 2019 it is a joint initiative of Diabetic Association of Bangladesh and NCDC, Non-Communicable Diseases Control Program, Directorate General of Health Services of the Government of Bangladesh. It looks like a very complex algorithm, but I'm choosing the key points. You see, if fasting plasma glucose is 10 to 14 millimole per deciliter, and hemoglobin A1C is 8.5 to 10, or random blood plasma glucose is 12 to 18, and the patient is symptomatic, along with lifestyle modification, you have to start insulin. If fasting plasma glucose is more than 14 and hemoglobin A1C is more than 10 and without symptom or with symptom, whatever it may be, you have to study insulin. Again, if hemoglobin A, I'm just choosing the key points. If hemoglobin A1C is more than 7, on treatment with first, second, or even the third agent, you can add insulin or you can switch over to insulin. Or as a fourth agent, you can add insulin. And then you intensify the insulin regime. Another thing is this, if hemoglobin A1C is more than 9% continuously for 3 months after initiation of treatment with any drugs, even with OAD, at any point you start or add insulin. This is the Bharas guideline in our perspective. So in all guideline you saw, we have to start with basal insulin. The basal insulin, how the stepwise we are initiating an intensification of insulin. You see, the basal insulin initiated 10 units per day, that is zero point 0.1 to zero point 0.2 units per kg per day, adjust by 10 to 15%, that is 2 to 4 units once or twice weekly to reach the fasting blood glucose target. If you cannot reach the target, then you add one mealtime insulin, that is basal plus only once mealtime insulin, that is the bolus insulin. The bolus should be 4 unit or 10% of the basal dose. This is very important. That should be 4 unit or zero point 0.1 unit per kg or roughly 10% of the basal dose. Dose adjustment is 1 to 2 unit or 10 to 15% once weekly. If still you cannot reach the target, we have to straight go for the basal bolus regime. That means one basal and 2 to 3 times separate mealtime bolus injections. And again, yeah, dose adjustment is 1 to 2 units or 10 to 15% once or twice weekly. You can initiate with split mixed insulin. And this split mixed insulin regime is suitable for switching from intravenous insulin to subcutaneous insulin. That is, whenever his patient is coming out from DKA or HONC or other parenteral feeding situations. Initiation in insulin naive patients, the starting dose of NPH and short-acting insulin typically be two-thirds is to one-third. That means two-thirds should be NPH and one-third should be regular insulin. And dose may be, you can calculate a dose like this, zero point 0.2 to zero point 0.3 unit per kg body weight. And regarding NPH, two-thirds of NPH, dose should be taken 30 minutes before breakfast. And one-third, it should be taken 30 minutes before dinner. So pre-meal insulin will be divided in 2 to 3 nearly equal doses. You can adjust the dose by frequent monitoring of SMBG, one self-glucose monitoring, and titrate the dose. There are some array of choice for premix insulin. There are various premix insulins in the market. There is biphasic human insulin that causes more hypoglycemia. Then you can use the biphasic analog insulin, that is aspart and other insulins are there. You can use this that causes less hypoglycemia and better control. But all these two requires a resuspension in the pen. Another is co-formulation, that is soluble insulin aspart, that rapid-acting insulin plus soluble insulin degludec. This is long-acting insulin that you does not require any resuspension, and there is flexibility of your meal time. So premix insulin, initiation and intensification. It can be started once daily with 10 units, either in the morning or at night. If the total insulin dose exceeds 20 units, then premix insulin can be given twice daily, before breakfast and before dinner. The The rule is two-thirds in the morning and one-third in the evening, usual in our context. Premix analogs should be distributed in two equal halves in the morning and evening. If you want to use the analog insulin, premix analog, it should be distributed like this: equal halves, once in the morning, once in the evening. 30 when the single dose exceeds 30. That means you have to start with single dose, and single dose, if it exceeds 30 units, then you divide the dose. Maybe started twice daily in case of patients with higher hemoglobin A1C. But there are exceptions. If the hemoglobin A1C is higher, you can divide the dose initially. Or if blood glucose, fasting and postprandial blood glucose, both are suboptimal. Suggested titration is 1 to 2 units added to pre-breakfast dose and pre-dinner dose every 3 days interval until target blood glucose values are reached. So analog premix formulation is more physiological profile with advantage of mealtime flexibility. You can take meal after 1 hour or half an hour or 2 hours like this. So higher maximum concentration versus biphasic human insulin, shorter acting versus human biphasic insulin, and faster start action also. This is again very important. This is a practical guidance on intensification to premix insulin analogs from basal insulin. If you are on basal insulin, if hemoglobin A1C you see, if it is more than 8%, you have to switch to premix insulin analog PIT. That is in the morning and in the evening as per rule. And if the hemoglobin A1C is 7 to 8%, fasting is more than 7, titrate basal insulin to achieve fasting less than 7. But you see, this is very important catch point. Fasting is if 4 to 7, then switch to premix insulin analog because then there is more chances to produce hypoglycemia. If you are in premix OD, that is only evening meal, if fasting is 4 to 7, then and hemoglobin A1C is more than 7%, add premix insulin analog PID. If fasting is more than 7, titrate premix insulin OD to achieve fasting less than 7. If significant hypoglycemia occurs during titration, also you intensify to premix insulin analog BID, not OD. So whenever you are shifting from OAD to biphasic or any insulin, you see the many studies show that the biphasic insulin hemoglobin A1C reductions is greater, 1.4 to 2.8%. So achieving treatment target with premix analog with up to 3 daily regime. This premix analog you can use 3 times daily, that is mealtime insulin. You see, if you can take OD, only 41% achieves the target. If you can take twice daily, 70%, and if you can take 3 times daily, about 77% people achieve the target. It is very simple to initiate and adjust the dose of biphasic insulin. You can start with once daily dose, that is 12 units during dinner, or twice daily start 6 units in the morning and 6 units at dinner. The pre-meal blood glucose titration. During titration, you have to look the pre-meal blood glucose level. If the blood glucose level is less than 4.4, you have to reduce the dose by 2 units. If it is 4.4 to 6.1, there is no need of titration. If it is 6.2 to 7.8, you have to up titrate by 2 units. If it is 7.9 to 10, you have to up titrate by 4 units. If it is more than 10, you have to up titrate by 6 units. But it should be every 3 to 7 days. This is, for example, another co-formulation is there, which I showed earlier. That is insulin, rapid-acting insulin and insulin degludate in a single pen. It is superior. There is the boost study in Japan. They show hemoglobin A1C is superior control. Control is superior in comparison to insulin glargine. Total daily insulin dose in comparison to glargine is same, but hypoglycemia, both confirmed hypoglycemia and nocturnal hypoglycemia are much less. That is 47% and 25% respectively. If you compare insulin glargine and insulin aspart with insulin degludec and aspart, you see regarding hemoglobin A1C, this is non-inferiority. That it is non-inferiority is confirmed significantly lower with IDEC as per the insulin dose. That means you require lesser dose of insulin and 10% lower risk of confirmed hypoglycemia. And nocturnal hypoglycemia also significantly lower. As I showed earlier, if I take the basal insulin, then adding aspart and basal bolus regime and intensify, there are many steps. But if you can take this co-formulation, you have fewer steps. That is basal insulin. From basal insulin, directly you can go to the IDEC aspart once daily. If control is not there, then you can go for IDEC aspart twice daily, and then intensify according to blood glucose level. It requires there is some recommendation that if you are taking this co-formulation, you have to wait for a few weeks to stabilize the dose. And if you want to switch from any regime to IDEC aspart regime, the dose to dose replacement is required. This is very important recommendation considering the initiation of the insulin. You have to consider several factors. What is the postprandial increment? If the postprandial increment is more than 3, that is premix insulin is required, most favorable. If the postprandial increment is less than 1 millimole per liter, then favors basal insulin once a day. If the patient likely to manage basal bolus therapy when intensification is needed, that is the patient choice, then favors likely to manage that favors premix. If not, that favors basal. If there is a large carbohydrate intake at 1 or 2 meals, then favors premix. If there are no large carbohydrate intake at 1 or 2 meals, you can start with basal because once daily dose. If the patient's lifestyle is predictable, that means eating pattern and working hours, if you can predict, then premix insulin is the best choice. But if you cannot predict, then basal insulin is the preferred choice. Again, what is the future intensification recommendations? Patient preference regarding number of injections is required. If prefers fewer injection, then you go for the premix insulin. If patient is comfortable with more injections, then you can go for the basal bolus injection. If the patient preference regarding self-monitoring and blood glucose is there, that prefers less frequent monitoring. And if the patient is comfortable with monitoring frequently, then it favors the basal bolus insulin. Patient ability you have to check for to inject. That is his cognitive ability, manual dexterity, need for caregiver is required or not. If it is there, then you have to give the less injections. That means premix is preferred choice. If cognitive function is okay and prefers patient ability is well, then basal bolus is the preferred choice. So we have to, during insulin initiation and intensification, what are the key points? We should not delay insulin initiation, titration, and intensification. As early as possible, we have to give insulin and manage both fasting and postprandial glycemia with insulin. So begin with the end. To keep in mind the end in mind. I came to the last of my presentation. This is the summary. As diabetes is a progressive disorder and there is inadequate secretion of the insulin and progressive destruction of the beta cell, so there is gradual deterioration of the glycemic control over a period of time. Insulin treatment should be started as early as possible, and delivery should be more physiological to achieve glycemic control. And you need to intensify the insulin therapy, and this is very crucial to achieve glycemic control over time. Insulin therapy is initiated in individuals with uncontrolled blood glucose level despite the use of oral anti-hyperglycemic drugs. You have to initiate insulin in persons who are taking also oral anti-hyperglycemic agents. Insulin, keep in mind the insulin intensification involves a complex regime to cover basal and bolus uh, glucose levels. But during intensification or initiation, you must keep in mind the side effects and benefits of giving the insulin or increasing the insulin dose. So thank you giving me the chance for an opportunity for giving me this presentation today. Thank you, the organizer.
After the